Okay, so welcome to Eat, Move, Think, the show about optimal wellness brought to you by Medcan.
Wow. Do it again.
Oh, I was practicing. Okay, ready?
Welcome
to Eat, Move, Think,
the show about
optimal
wellness brought to you by
Medcan.
Yeah, this is extremely good. Thank you.
Okay, Chris, I have a stat for you. It's
Okay,
pretty
I'm ready.
surprising. 1 in 3 Canadians is living with diabetes or pre-diabetes today.
1 in 3.
Yeah.
Wow. That is alarming. And I think it happens a lot. You go in for your annual assessment and the doctor talks about that you're on the road to type 2 diabetes, that
Right.
you're pre-diabetic, talk about things like insulin resistance. And you hear that stuff and then what do? Like the doctor tells you probably in the moment, but I think a lot of people forget. It kind of goes over their head. And then they're looking for resources.
Well, that's exactly what we're going to do in this episode. We are providing that resource for you if you have just been told by your doctor that you are insulin resistant.
Or pre-diabetic.
Yeah. If you're on your way to diabetes, and these are helpful tips for you to start doing in your daily life now to possibly even reverse your diagnosis.
I'm Chris Shulgin.
I'm Jasmine Ratch. We're the producers of Eat, Move, Think. So today our episode is hosted by Dr. Peter Nord, our wellness host and Medcan chief medical officer. And he's in conversation with Dr. Susan George. She recently joined Medcan's team as an endocrinologist, and she's also a professor of medicine and pharmacology and toxicology at the University of Toronto. She's a clinician scientist in the division of endocrinology at the Toronto General Hospital, part of the University Health Network. And in 2020, she was named to the Order of Canada.
Wow, she's a heavy hitter.
She's a legend in the field. It's awesome that she was named to the Order of Canada, and we're really excited to have her on this episode today.
Amazing. Here's Dr. Peter Nord in conversation with Dr. Susan George.
Welcome back to Eat, Move, Think, everyone. We have another one of our expert Medcan consultants on the show today, and it's her first time here. Dr. Susan George, welcome. How are you doing today?
Thank you very much. I'm well, thank you.
Good. So you're an endocrinologist at Medcan and on University Health Network. Maybe we should start by telling our listeners a little bit about what that means. You know, endocrinology is a broad field. What does it look like when you have your existence clinically day to day?
Well, an endocrinologist, as some of you may know, is someone who deals with the endocrine system, which deals with all of the hormones in the body and the glands that make these hormones. So ranging all the way from insulin from the pancreas, which we're going to deal with in some detail today, but also hormones from the thyroid, from the ovaries, or the testicles, and also from the pituitary gland. So an endocrinologist is a specialist physician who deals with disorders of the endocrine system, performs investigations to figure out what might be the problem, and then would guide the person through the treatments, appropriate treatments. So in terms of what I do, I'm what one calls a clinician scientist. So I do clinical work and also participate in laboratory research, actually looking at some of the signaling mechanisms that hormones and transmitters in the brain work through. So I sort of have a dual existence in terms of doing clinical work as well as doing laboratory research at the University of Toronto.
So what got you interested in the field?
Well, I think, going back to my medical school days, I was fascinated by sort of the checks and balances in all of the endocrine systems. And I mean, what is amazing is that things go right most of the time in our lives. But when things do go wrong, there's a very organized way to investigate the endocrine system. And many treatments are available for many of the conditions that might be problematic. So I was very interested in sort of this investigative aspect of it, and also the fact that, one is able to treat many of these conditions and derive satisfaction from that.
Oh, that's great. Yeah, it seems like we call it homeostasis, but it's interesting how the body with hormones keeps everything in balance.
Right.
And if things get a little out of balance, that's when folks like you can come in and get things back to normal.
In most cases.
Yeah,
right?
That's great. So this year it was announced that diabetes is now the condition which drives more drug claims in Canada than any other disease process. I guess, what does that mean for Canadians? Is diabetes now more prevalent than it was last year, or is it that the drug treatments are changing?
I would say some of both. Diabetes is sort of undergoing a huge uptick in terms of prevalence or the incidence in the number of people who suffer from diabetes. Now, there's two types of diabetes. You've probably heard of diabetes type 1 and diabetes type 2. So the most common one that we are dealing with is type 2 diabetes. And I'll just say a few words about type 1 diabetes and sort of to get that out of the way. It's far less common, type 1 diabetes, which is actually an autoimmune condition where people make antibodies directed against the cells in the pancreas that make insulin or against insulin itself. And therefore, these individuals have a deficiency of insulin. So their treatment is totally different from mostly the type 2 diabetes that we are going to address today. So type 2 diabetes, or people afflicted with type 2 diabetes, have initially a surplus or a surfeit of insulin because they have insulin resistance. In other words, it requires more insulin to do the job that a normal physiological level, doesn't suffice. So initially, we have insulin levels that are higher than normal, and then eventually you get sort of fatigue at the level of the pancreas, and then they might not have enough insulin around. So the treatments that we devise for this condition would vary depending on whether there is insulin around or whether you arrived at a stage where there's insufficient insulin. The scary part is the incidence of diabetes, not just in Canada, just worldwide, is rapidly escalating. In Canada, Diabetes Canada has put out some numbers. In 2022, it was about 5.4 million individuals have type 1 and type 2 diabetes. Now, type 1, as I said, is only 10% of that number. The rest are all type 2. And then there is a huge number of individuals with prediabetes, many of whom may not even be aware. And the total number of that is over 11 million. So right now, it's 1 in 3 Canadians have either diabetes or prediabetes. So it's a very scary large number. And the overall, incidence is about 14% of type 1, type 2, and this prediabetes, and postulated to increase to about 27 or 28% by 2032. Wow. So in 10 years, it's going to double. So it's a very scary statistic. Mm-hmm. The treatment of diabetes costs us about $13 billion a year in Canada. And obviously, there are some populations that are more predisposed, but, the incidence, no matter who you are, appears to be increasing.
Maybe you can talk a little bit about what diabetes does to the body, signs and symptoms that could lead people to think they might have diabetes, but ultimately thinking, what's the pathophysiology? What happens to those end organs as a result of having more sugar at the end of the day in the bloodstream?
Right. So sugar, or glucose, is a molecule that's essential for all the processes in all of the cells in our body. So right from our brain cells to our heart cells, our kidney cells, our muscles, liver, other organs, all require glucose to function properly. So it's sort of the metabolic or the fuel system in the body that's absolutely necessary. We get most of our glucose from our diet, or our liver is capable of making glucose in situations when we're not eating. And the hormone insulin, which comes from certain cells in our pancreas, is what allows the body or the cells in various glands and organs to utilize this glucose by allowing it to be taken up into those cells in order to enter the metabolic pathway. I mean, we'll talk about some of the misconceptions that people know, but if you've eaten something and there is glucose, your pancreas, puts out a spurt of insulin, which allows circulating glucose to be taken up by your muscle cells, your liver cells, your fat cells, in order to use them, as well as your brain cells. So that's how the physiology works. If there's insufficient insulin, or if we have insulin resistance, then obviously the levels of insulin are insufficient to do the job. and the glucose can build up in the blood, and that is what constitutes diabetes. So we have criteria done on lab tests to make that diagnosis. And if there is too much glucose in your bloodstream, it affects many processes in a derogatory way. It causes a lot of damage, inflammation. It affects the immune system. It affects functioning of your brain, to functioning of your heart, your blood vessels. So all of the consequences of diabetes that we know about, the side effects, are a result of the glucose, the sort of toxicity of that high glucose that it exerts on all of the systems in your body. So the symptoms that people may experience as your sugar is rising is increased thirst. Their mouths are dry, they're putting out more urine. They might have to get up during the night to pass urine, whereas they didn't do that before. Some people experience, damage to the nerves, and they get tingling in their extremities. They can get damage to their eyes. It can get damage to your brain. It can affect cognitive function, your heart, your cardiovascular system. It makes you prone to heart attacks, affects kidney function. People can go into renal failure, amputations through blood vessels. So a whole host of horrible things can happen if it's left untreated.
Pretty much every organ in the body at some point would be affected.
Precisely, yes.
Yeah, so those are critical. So I think that gives us a bit of a sense of, okay, what is diabetes? What is the ultimate result of having excess glucose in the system? You mentioned prediabetes a couple of times. Maybe we can move there and kind of say, okay, what is that? And I sort of think about it as the iceberg. What we can see is the diabetes, and then what's underneath the water is prediabetes. And how do people know if they have prediabetes? How do we define what that is? Are there markers that we can be using to look for prediabetes?
Yeah, that's a very, very important question, because prediabetes can be present for a good decade before people become actually diabetic and have some of those symptoms that we talked about. So prediabetes, is something that, working with your physicians, adults over the age of 40 or 45 should be screened for it. And if the results are normal, then that screening is repeated again in a couple of years. And people who have a family history of diabetes, or who are on drugs that we know can elevate the blood sugar, or have, belong to particular ethnic populations where we know that diabetes is more prevalent, people who are very sedentary in their lifestyles, or have other risk factors for some of these other conditions, such as elevated cholesterol or hypertension, should be screened regularly for diabetes. So the screening tests are, blood tests and possibly a urine test to figure out whether you have diabetes. So we have specific criteria as to what defines the diagnosis of diabetes, and then we have criteria that defines prediabetes. And prediabetes should be taken seriously. I see many patients who say, yeah, I was told my blood sugars were slightly abnormal 10 years ago. But slightly abnormal is not to be ignored. It really needs to be dealt with aggressively, because we know what the consequences can be.
Yeah, I know part of the challenge that we've had at Medcan is, even when individuals come for their annual health assessment, we run a battery of tests through their blood sample. And we have normal ranges that come up with the lab. And those normal ranges are actually the average Canadian. And if we already know that there's a big percentage of the population that would be considered abnormal, they're factored into that. So what I tell patients is, okay, you are normal, or you're as normal as the average Canadian, which isn't saying much. We actually aim for greater than that. We want you to be healthier. We want you to be in the top 10% of Canadians, not in the 50th percentile. And so we're driving, I think, for targets that are much more aggressive and end up demonstrating better health longer term, so health span and lifespan. And so maybe we can just talk a bit about hemoglobin A1C, because that's one of the markers that pretty much everybody's going to be getting. If you've come through Medcan, if you've touched, whether it's our urgent care or family practice environment, dedicated care, or the annual health assessment, good chance that at some point you're going to have a hemoglobin A1C. So maybe you could just explain what that is compared to just a a random or a fasting glucose measure and why it's helpful in terms of determining where somebody is on that spectrum?
So a random glucose measure is not that helpful unless you knew when the person ate last in order to interpret it accurately. And then from the time you do your blood test to when it comes to the doctor, it's not recorded anywhere when you ate last. So that may not be very helpful unless it's a truly fasting determination. So the glycosylated hemoglobin, or abbreviated as hemoglobin A1C, is a measure of a fraction of hemoglobin, which is what we have in our bloodstream, that carries the oxygen around, which gets glucose molecules tagged onto it if the sugar or glucose levels are elevated in your blood. So such as after a meal or, if they're elevated, the hemoglobin A1C is elevated. And that gives us a much better measure because it does not depend on when you've eaten or someone having to figure that out. And we have criteria that define diabetes and criteria that define prediabetes. So Diabetes Canada, the Canadian Diabetes Association, and also the American Diabetes Association, they have over the years figured out what our criteria are. And I think every physician needs to be educated about how to interpret that. So as you say, not just to look at the so-called normal range and dismiss it as being okay, when in fact it might not be. The other thing also is people's weight should figure into that, especially visceral fat. That is sort of the really bad accumulation of fat. So other factors and some of the risk factors that I mentioned, all of that has to be taken into account in interpreting that hemoglobin A1C and whether it's appropriate for the person you are seeing.
And I like to describe to my patients the fact that glucose can go up and down by the minute, essentially, in our bloodstream, but the hemoglobin A1C kind of zeroes out all the peaks and the troughs, and it looks backwards 6 weeks or so.
Yeah, up to 3 months.
Yeah. So it gives us a bit of a sense of history, which is how has it been doing on average over the last couple of months, and then gives us a sense of how is it actually. So it's a very accurate, because rather than relying on even fasting and what did you eat last, and it gives us a bit of a sense of an accurate measure because it's a trend that's been over the last couple of months.
And a stable one.
And so also when we think about what the results should be, we talk about sort of 6% versus 6.5%. And so now, as you said, it's percentage of the hemoglobin that's glycosylated. And we obviously look for people to be in the 5s, not in the 6s. And then also, I think, is the trend. So if you were 5.3 1 year and then you come back again and you're 5.5 and then the next year 5.7, and we can look backwards.
Yep.
And even though you're considered air quotes normal, if the trend is going in the wrong direction, that's also a pretty big red flag. Maybe you can describe too what the oral glucose tolerance test is, because that often is another way that we can, and even if you're in the 5s or the high normal sort of range, sometimes we can use this oral glucose tolerance test to help define even more specifically, like what's your insulin reaction and what's your sugar reaction to a defined dose.
Right. Well, the oral glucose tolerance test, we used to use it a lot more frequently, sort of years ago. It's come to be regarded as not as necessary in every individual that you're screening, whereas the hemoglobin A1C and possibly a fasting glucose should suffice. But there are situations where the oral glucose tolerance is very helpful, particularly in, say, gestational diabetes. So women who are pregnant, and it's actually now mandatory in Canada that between the weeks of 21 and 24 that they all get a glucose tolerance test, because the prevalence of diabetes and the complications even during a pregnancy are so vast that, detecting this ahead of time and then being able to treat these women, has really improved outcomes, not only for the pregnant woman, but also for the infants. So that's when it's absolutely mandatory. But otherwise, if you're unsure or someone's borderline, you could use the oral glucose tolerance test. The thing is, there are two types of insulin secretion, right? One is sort of the basal level, such as when we're fasting overnight and not eating. So that's why the fasting is sometimes a good measure reflective of that. And the oral glucose tolerance test tells us how we respond to a stimulus in terms of a meal. However, what's in that awful drink that they give people is just pure glucose, but it's standardized and quantified, and we know how to interpret it, without the problems of what did you eat, when did you eat, etc. So in that way, it's standardized, and then we have criteria for what the number should be 1 hour after that drink or 2 hours after the drink, which is our standard time to determine the abnormality.
So is prediabetes the same thing as insulin resistance?
Yes and no. Many people with prediabetes have insulin resistance, but not everyone with insulin resistance has prediabetes.
Mm-hmm.
There are many conditions that cause insulin resistance. And what that means is if we don't measure insulin levels in everybody, but we know that insulin resistance is seen in particular conditions, and it certainly increases the risk for all of those complications we talked about. And not everyone has prediabetes, but it's something to take very, very seriously as well.
Yeah. So let's say I've gone to my doctor and it turns out that I've got prediabetes. Are there things that I can do at that point to reduce my risk further?
Absolutely. So at that point, the doctor and you should take stock of what your weight is relative to your height. We commonly use a measure called the body mass index, but it's sort of fallen into disfavor a little bit because it doesn't necessarily, take into account that visceral fat that I was talking about. So this is fat that's accumulated around your middle and the abdomen and surrounding the organs in your abdomen, which poses a much greater risk than subcutaneous fat, which is what, we see in people with simple obesity, we call it, where subcutaneous fat is increased, but that doesn't pose as great a risk as this visceral fat. So one of the measures we use is a waist circumference, and that should be under 40 inches for males and under 35 for females. So that is something that a doctor should be measuring and keeping track of it in a serial way. And people can do that themselves. So I would define a point of reference. So say your belly button, your umbilicus. So measure your sort of girth at that point and then use that serially to see if things are going in the right direction or not. So that's your weight, and then your diet. So take stock of your diet. Obviously, a measurement of what your cholesterol and triglycerides are would be helpful to sort of design specific measures to be aware of. Otherwise, if it's simply weight reduction, then it's total calories that matter. And in our society in Canada and North America, it's really portion control that's absolutely vital. So, there are many guidelines if you go on the Diabetes Canada website, for instance, in terms of, your servings of fruit and lean protein and vegetables. And people are tending more and more to sort of a plant-based
Mediterranean diet. Mm-hmm.
Mediterranean diet, using plant-based oils, for instance, staying away from animal fats and so on. And away from juices, moderate your alcohol. Water should be the preferred drink for everybody. People drink very little water. That is a problem. So I think moderating the diet and obviously increasing your physical activity is vital. So these are the ways in which to reduce insulin resistance and sort of delay progression to frank diabetes. And then there are some medications that function as what we call insulin sensitizers, and they reduce that insulin resistance. So the chief one among them that we use at the moment is metformin, which allows the circulating insulin that you have work in a more efficient manner, and it can reduce insulin. There's another category of drugs, we use them less these days, thiazolidine diones. One of them, pioglitazone, we use sometimes, but metformin is really the mainstay. It has been shown to delay the progression of prediabetes and insulin resistance into frank diabetes. So it's a very valuable drug. But all these other measures, I tell patients, go hand in hand. So the diet and the movement and exercise is as important as if I wrote you a prescription for some medication, if not more so.
They all work hand in hand in true eat, move, think fashion.
Absolutely, yes.
That's it. And you mentioned visceral fat, and just to call out that as part of our annual health assessment, we do a pretty rigorous body composition. And one of the results that comes up is a little graph, and it shows actually the visceral fat where they are at that particular time relative to the sort of the sweet spot, which in terms of in area our measure is 100. Almost no matter what age, almost like when you have girth circumference less than 40, we have this number of 100, and we want to make sure that people are always less than that rather than above that line. It's a really important risk factor that we pick up as part of the annual health assessment. Like the body composition part is extremely helpful and very, very accurate too. When I have my AHA patients, I always really focus on this little graph, very visual, so you can sort of see exactly where you're sitting. And if there's somebody who's above that line, we end up developing a whole recommendation plan, obviously that involves exactly as you said. So the sort of the diet side, exercise, and then if needed, medication recommendations as well.
I just also want to just mention fatty liver.
Yeah.
If you have it around these organs, the fat in the liver is another big risk factor. And that is something that's, very, very prevalent in this population that we're talking about.
Yeah, and that's also something we pick up pretty commonly, or non-alcoholic fatty liver disease, or NAFLD. So yeah, I'm glad you brought that up, because that's another aspect that we can pick up on an annual health assessment, determine people. We basically call them mild, moderate, severe. And then if it's in the moderate or severe, we can dig a little deeper with a specific liver health assessment to kind of define that further. Is there any particular kind of exercise that has been shown to be beneficial?
Well, actually, two kinds of exercise. So both aerobic exercise and resistance training exercise. So aerobic is, any exercise that increases your respiratory rate and your heart rate. So brisk walking, treadmill, running, whatever is your preference is okay. We can talk about how long and so on, intensity. So that's one thing that's necessary, the aerobic exercise. And then resistance training. So this is whether it's with weights or elastic bands or a weight machine or even your own weight. So, I sometimes tell people who are not very keen on jogging or anything to buy weights that they can strap onto their ankles and wrists and walk with that. So, which is more than just moving your own weight around. And that can be helpful. And also for bone density, because with diabetes, there is a higher incidence of bone loss. So it can certainly, impact that, but resistance training is very important. Now, recently, there have been a lot of studies about interval training, where, they talk about doing these are people who can do it, obviously, vigorous exercise for a short period of time, followed by, a few minutes of lower intensity or even rest, and then do this, in an alternating fashion, which seems to be very beneficial. And the amazing thing is there are some studies that show even a few minutes of vigorous training spread out even at several time points during the day is helpful, rather than doing sort of a cumulative stretch of 30 or 40 minutes as we've heard about in the past. So, that's something people who don't have a lot of stamina or can't do it for very long may want to think about too.
And obviously doing it at a frequency that makes sense too. So doing that once a week, probably not. Doing it every day, big effects. I'm always recommending if it's 30 minutes a day, it's 30 minutes a day. And life may get in the way and that becomes 4 or 5 times a week. But if you're aiming for 4 times a week, life gets in the way and you're down to twice a week, and then you're not really getting the benefit of it. So daily habit. I love the hand and ankle weights, because then you're combining aerobic and resistance at the same time. So it's super time efficient as well. And what about sleep and stress? Has been some work looking at the effect of sleep and stress quality on diabetes and your overall sort of propensity to have diabetes if you have prediabetes.
Yes, chronic stress, as you know, is a very detrimental factor for many chronic disorders, and particularly can affect diabetes control, can create insulin resistance. Stress in all of our bodies causes the release of hormones that are anti-insulin in nature, such as cortisol, which comes from our adrenal glands, but it's our pituitary gland and hypothalamus that regulate that, and also from adrenaline, noradrenaline type hormones, which come from the adrenal gland or from your sympathetic nervous system. These are anti-insulin in that they oppose the actions of insulin. They independently cause blood glucose to go up, and therefore your body needs to put out more insulin to counteract that. So if you didn't have insulin resistance, this can create insulin resistance. And if you already had insulin resistance, obviously it can make it worse. So chronic stress and even anxiety, which raises these same hormones, can be very detrimental in sort of the not only creating insulin resistance, but also its progression to diabetes. And if you're already diabetic, it can make the control of diabetes that much harder to achieve. And then sleep, the importance of sleep is becoming clearer in so many of the chronic disorders we deal with. So sleep sort of resets everything from your brain function on down. And if you have too little of it, those processes don't happen. All of the neuropsychiatric disorders we deal with, one of the very earliest symptoms is impairment of sleep. So whether it's depression, anxiety, even more serious neuropsychiatric disorders, sleep regulation, that alteration, that circadian rhythm is something we see very, very early. And in the case of insulin resistance, the lack of sleep, again, raises these anti-insulin hormones. And there are many others in the body, like glucagon and cholecystokinin. There are many others that we don't necessarily measure. And they also exert sort of an anti-insulin effect, increasing insulin resistance. And there are studies that show that with diminished sleep, that people are anxious and irritated maybe the next day, but also their appetites are bigger. They have a tendency to choose inappropriate things in their diet, such as fast foods and so on, which make everything worse. And satiety mechanisms can be impaired, so you want to eat more if sleep is impaired. So sleep is a very important, actually the CDC, the American Centers for Disease Control, put out an advisory about sleep and diabetes, recommending minimum of 7 hours of sleep for individuals overnight. And it's obviously very, very important.
Yeah. Is there a way to reverse insulin resistance or reverse diabetes?
Yes, because type 2 diabetes, is so dependent on these lifestyle issues that we talked about, that if people were at an ideal lean body mass with reduction of, sort of adiposity in the central region, were following the diet and exercise regimen that we all recommend, there's absolutely a way to, if they're at their ideal body weight, and maintain sort of regular exercise in way to reduce it. I've seen patients who've been able to come off medications, having present to hospital even with florid diabetes, requiring insulin, following strict measures that we talked about, able to come off their medications and live pretty well.
That's
so
great.
I do think it's possible.
Well, we covered a lot. If we were to say, what were the big three takeaways? What are the three most important things that our listeners can do to prevent or manage insulin resistance, prediabetes, or frank diabetes?
Well, eating healthily, moving more, losing weight, and getting enough sleep. That's 4 things, actually.
Yeah, but that's right to the point. That's easy. That's great. A great way to end. So these are really important tips. Dr. George, thank you so much for sharing your expertise. Take care and stay well, everybody.
Thank you. My pleasure.
That was Dr. Peter Nord, Medcan's Chief Medical Officer, in conversation with Dr. Susan George, Medcan endocrinologist, professor at the University of Toronto, and clinician scientist at Toronto General Hospital.
You can book an appointment and learn more about your insulin levels by emailing bookingteam@medcan.com.
Follow Medcan on Twitter and Instagram at MedcanLiveWell.
We'll post episode highlights and other links that you can check out on our website, eatmovethinkpodcast.com.
Say hello and send us a tip or a suggestion by emailing us at info@eatmovethinkpodcast.com.
Eat, Move, Think is produced by Ghost Bureau. I'm Jasmine Ratch, managing producer.
I'm executive producer Christopher Scholgen, and social media and strategy support is from Chantal Gertin, Andrew Imex, and Emily Bozic.
And we'll be back soon with a new episode examining the latest in health and wellness. This podcast episode is intended to provide general information about health and wellness only and is not designed or intended to constitute or be used as a substitute for medical advice, treatment, or diagnosis. You should always talk to your Medcan healthcare provider for individual medical advice, diagnosis, and treatment, including your specific health and wellness needs. This podcast is based on the information available at the time of preparation and is only accurate and current as of that date. Source information and recommendations are subject to change based on scientific evidence as it evolves over time. Medcan is not responsible for future changes or updates to the information and recommendations and assumes no obligation to update based on future developments. Reference to or mention of specific treatments or therapies does not constitute or imply a recommendation or endorsement. The links provided within the associated document are to assist the reader with any specific information highlighted. Any third-party links are not endorsed by Medcan.